So if everyone can get to their seats with their lunch, I did promise you would get lunch, but we do like to have our lunches be working lunches. We have the benefit today of having an excellent speaker addressing us on a very important topic. David Cutler has developed an impressive record of achievement in both academia and the public sector. He is currently the Otto Eckstein Professor of Applied Economics in the Department of Economics and was named Harvard College Professor in 2014. Honored for his scholarly work and singled out for outstanding mentorship of graduate students, Professor Cutler's work in health economics and public economics has earned him significant academic and public acclaim. Professor Cutler served on the Council of Economic Advisors and the National Economic Council during Clinton administration and has advised the presidential campaigns of Bill Bradley, John Kerry, Barack Obama, as well as being senior healthcare advisor on the Obama presidential campaign. Professor Cutler is a research associate at the National Bureau of Economic Research and a member of the Institute of Medicine. He advises many companies and groups on healthcare. Professor Cutler was a key advisor in the formulation of recent cost control legislation in Massachusetts and is one of the members of the Health Policy Commission created to help reduce medical spending in the state. He's the author of several books, many papers, and I can tell you from experience he gives a very good talk. Please do me the favor of joining me in welcoming David Cutler.
Thank you, John. With an introduction like that, how could I fail but to disappoint you? I am actually, whenever I'm introduced kindly, which is increasingly rare, I like to think about a comment that my former dean once made. You'll understand why I'm glad that he's the former dean. He said, if you lined up all the economists in the Harvard Economics Department end to end, that would be a good thing. So I will try to maybe show you a little bit about why that might not be so accurate. What I want to talk about today is a body of literature on the relationship between income and longevity. What I'm going to tell you about today is the longevity end. I understand, obviously, that we care about quality of life as well as length of life, and so I will, at the end, come back to what we don't know about the relationship between disability and income. And there are some things that we do know that look similar, but there's a lot we do not know that we would like to know about. But for reasons that I'll tell you, I'm not going to be able to tell you about them in the data today. So this is work that I've been doing for a while. A good part of it was published in JAMA in 2016, and you can see the list of co-authors there. I will just note, actually, that all of the data that we have used to form mortality rates and life expectancy at the area level and by income and so on are all publicly available, actually. And so either if you go on the JAMA website, you can find a link to it, or if you go to, we've actually set up a website with it called healthinequality.org. You can go there and access, you can't access the micro tax data there, but you can access all of the other data there. And the final disclaimer before I start is that I feel a little bit like the two guys at Car Talk who tell you you've wasted another perfectly good hour of your life listening to them. The opinions in this paper do not reflect the IRS, the Treasury Department, the Social Security Administration, or any other agency of the federal government, although one could wish opposite, but they do not. Okay, so let me tell you what it is that we were thinking about. It is well known and has been for some period of time that income and longevity are related. So people in higher income live longer than people in lower incomes. Nonetheless, it's actually, there are several aspects of that really haven't been so well known, and I just sort of list a couple of them here as sort of motivating factors. One is kind of exactly the shape of that. That is, I give my classes the following quiz, which I will give you in this room. There's got to be an income level at which more money cannot buy stuff that make you live longer, right? So you imagine that at low levels of income, as your income rises, people will live longer. presumably there's some upper income limit at which when you reach that upper income limit, more money in a year does not help you live longer. So I want you to take a second, and I want you to come up in your mind with what income you think it is that above that level of annual income you don't live longer. Okay? So I want you to decide what level of income above which you don't live longer. All right, everyone have the answer? Okay, how many of you in your answer believe that the answer is at or below $100,000 of annual income? Okay, how many of you believe that it's between $100,000 and $250,000 of annual income? How many of you believe that it's above $250,000 of annual income? How many of you believe that there is no income at which additional income is not associated with living longer? No one in this room believes that? One person, two people. So I will tell you that those two people are correct and everyone else is wrong. So that's what I meant by telling you that there are basic things about the shape of this relationship that we don't really know. How is it changing over time, and what are the implications for policy? So that's the nature of what it is that we were out to explore. I'm not going to tell you in enormous detail about all the data and analysis, but I will tell you a little bit about what we did. We started off with data from tax records, actually. So as part of this research, the sort of IRS and the Treasury Department part of this research was data on all tax returns that are filed to the Treasury every year. So that's 15 years, so about 1.4 billion observations, which may be greater than the sum total of all the observations I'd ever worked with in any previous analysis I'd ever done. So we have de-identified tax returns, so we have household income, and then people are ranked every year. So we actually get a percentile rank from 1 up to 100. Okay, and so based on like the national income distribution, where do you fall? National age and gender income distribution, where does one fall? And then the IRS links the data to Social Security death records, so we have a measure of mortality. And so from that, we can construct mortality rates for each age and gender at each income percentile. Okay. Now, the thing you worry about is that at really young ages, where you are on the income scale is not a good reflection of where you're likely to wind up on the income scale. So actually, you have to start with people who are a little bit older here. And so, so what I'm going to show you is life expectancy for people at age 40. The income tax information does not have information on race or ethnicity. So we, ex post, we correct areas for known differences in longevity by race and ethnicity. So what we want to get is kind of for a standard type of person, what is the mortality rate or the life expectancy for someone, for a constant type person, say across different areas or in different years. And so we're going to do that. The one thing that's important here, and it's sort of related to the disability, it's difficult to know if someone filed a tax return in a particular year. Let's say they didn't report any income. If you don't see them in subsequent years, have they passed away? Or are they still alive but not filing anything because they don't have any income to report? So we can tell if people have any wage income, but we can't tell if people don't have that, because if there's wage income, there will then be some kind of reporting form. So we have to actually leave out people with zero income here. And so that's actually one of the limitations, which is that some of the people who are very hard to get at, who you'd like to get at, we can't do here. Okay, so let me just sort of show you an example of something. So what I'm showing you here are mortality rates by age for exact percentiles of the income distribution. So the upper blue line shows you the mortality rate at each age. So remember, we can do this by age. At each age for people who are in the 5th percentile, that is the 5th from the top, so people with very high incomes. And the red dots are showing you for people who are in the 95th percentile, towards the bottom. Income is not a particularly good guide post-65 as it is pre-65. That is, the correlation between reported income on tax forms, even a decade apart, is very high below 65, but it drops off after 65. So we can't go to the highest ages here, even though such people will file income tax forms, but we don't trust that they're picking up the same percentile in the distribution. So all we can do here is find people who we observed at some point before retirement age. So that's why there's an upper age here in the mid-70s. That is, those are people who in the earliest years we observe pre-retirement, and then we can observe later on their mortality rates. So these lines fit very well, and this is going to be important for us because what we basically do is we forecast out these lines, and I'm showing you the forecast here. So we forecast out these lines, which is the sort of old Gompertz relationship back from the 1820s in terms of the beginnings of demography. And then we use that to say, now we've got a life table for people who are in the 5th percentile of the income distribution and people who are in the 95th percentile of the income distribution. We can do this by each percentile of the income distribution. We can do this for each year. And we can also do this for each area of the country. So we can do mortality rates, and basically I can turn that into a life expectancy because I know what the mortality rate is at any age. So I can turn that into a life expectancy at each age, each year, and each part of the country. So that's an enormous amount of information. What I want to try and do is summarize it for you and sort of show you a little bit about what that gives you. So here's the first part of what it gives you. Although some of it even, you get into small samples. So for example, people at the 5th percentile of the US income distribution in Detroit in 2012 is not a very large number of people. So that's something that we have to, there will be cells that we have to address. So this is the sort of basic chart. So this is across all the years. What is the relationship between one's income, and think of this as kind of a lifetime, as an annual income over one's lifetime, and the expected age at death for people who are 40 years old initially. Okay, so the average remaining life expectancy of such people is about 40 years. And here's what you can see, which is that it increases as people get higher income, it increases, and it actually increases pretty monotonically. That is, this is coming back to the quiz I gave you. There is no income at which higher income people do not live longer than lower income people. So that is, people earning $2 million a year have lower mortality rates, live longer than people earning $1 million a year. The graph is certainly steeper at the lower end. That is, a given increment to income is associated with greater longevity at the low end of the income distribution, but it never disappears. Notice, by the way, that I'm using a lot of the words is associated with and is correlated with and not is caused by. My suspicion is that the additional $1 million between $1 million a year and $2 million a year doesn't cause anything, but it's associated with increased longevity. Just to give you a sense of the magnitudes of this is for men. The top 1% of men will live to about 87. The bottom 1% of men will live about 15 years less long than that. If you wonder whether 15 years is big or small, let me give you a couple of metrics as to how to think about that. One is, how many years do you, on average, live less long by smoking, by being a regular smoker? The answer is about 7 to 10 years. So this is more than everyone in the bottom smokes and nobody in the top smokes. Another way to think about this is if you look at the if you look at life expectancy in the US compared to other countries, you can see that at the top, the US is in the highest income people in the US live longer than people in any other country. And even the median is not so bad, but if you get down to the 25th percentile and, God forbid, the 1st percentile, you're seeing enormous reductions in longevity associated with that. Women have a slightly less steep gradient with income than do men. Women always live longer than men do, although men come close to catching up as you get to high income percentiles. Women appear to be more resilient to falling income than men are. So as income falls, male mortality goes up by more than female mortality does. And you can see that pretty clearly in the lines here. You can also see that when I just show you directly the gender gap, where it's much smaller at the high end of the income distribution. So that's our sort of first set of results, which is that the gap is immense and that it's different by gender. We then wanted to ask things like, how is it changing over time? And we have obviously very, very recent data. So what we did to look at this is we divided the population into quartiles because we're worried about small numbers here. So we divided into quartiles of the income distribution. And then what I'm showing you here is the expected age at death in different quartiles over time. So in the blue line down at the bottom, this is the bottom quartile. Consistent with the previous figures, the expected age at death is lower for people in the lowest quartiles. Okay, so that's what you see is that expected age at death goes up as you move into the higher quartiles. What I want you to focus on here is the slopes of these lines over time. That is how they're changing over time. There's been data showing that in the late part of the 20th century, the gap in mortality grew. We hadn't had such recent data. There have been a couple of conflicting claims about it. So there's a claim by J. Olshansky and colleagues that particularly for women, which I'll show you next, life expectancy is actually falling at the bottom end of the education distribution. They were looking at women without a high school degree, although it was pointed out that that was an increasingly selected part of the population and various controls had been done to try and adjust for that. Here, if you look for men, what you see is that as you move up in the income distribution, not only is life expectancy higher, but it's increasingly so. We don't find that men at the bottom, in the bottom quartile, are living less long, but the increase in life expectancy is relatively low for them. That's actually particularly true if you look at women, where you can see the gaps getting even more pronounced. So even up to very, very recent periods, what you're seeing is that high income is associated with increasingly longer life. That has a lot of implications for things like the progressivity of Social Security, progressivity of Medicare, the progressivity of Medicaid as it pays for the elderly, which is that the number of years that one is going to receive benefits is changing disproportionately. And at least it made me think very differently about statements like the following: as a country, we are living longer, therefore we should increase the age of eligibility for social insurance programs. I don't want to talk about whether that's a good idea or not. I just want to note that the we're living longer is actually not a uniform statement. And so therefore, the policy that comes from it being a uniform statement is something that you want to think about. My job here is not to do policy. My job is just to point out where some of these findings will have some relevance. We were particularly interested in why these are the case. And so in order to get a bit at why these are the case, what we did was we tried to look at different geographic areas. So we divided the country, not we, there are various ways of dividing the country. I think David Otter was one of the first to use this analytically, was to look at the country by commuting zones, which are roughly MSAs, but they sort of organize the whole country, not just urban areas. And so we're going to calculate life expectancy at age 40 by income for each of these areas. Okay? So we're going to say, what is it in each of these 700 different areas? What is life expectancy at age 40? And then we're going to gather a bunch of information about those areas, and we're going to try and relate it to that and see what it's related to. Okay? So this is showing you a map of the expected age at death for men in the bottom quartile of the U.S. income distribution. So we can have men and women. The female picture would look pretty similar to the male picture here, but I'm not going to overwhelm you with pictures. They will look different for high-income people than for low-income people. So actually, for low-income people, there's much more geographic continuity of areas with high and low life expectancy. The darker reds here are areas with low life expectancy, and the lighter yellows are higher life expectancy. And then the crosshatches are areas where we don't have enough data to say anything with much confidence. One of the things that should strike you about this is that, of course, the area that you would have expected people would live less long is in the Deep South. And yet the Deep South is basically about average on this picture. What this is actually picking up is that the people in the Deep South have lower life expectancy, but that's basically associated with the fact that they're poor. When you look at controlling for income, the area of the country that does very poorly is this belt that goes from sort of West Virginia and Kentucky down through Oklahoma and Texas. That's actually the area where life expectancy is the worst. It's the area where opioid-related deaths are the highest, although this is by no means accidental poisoning deaths. That's not the biggest part of this. Heart disease mortality would be the biggest part of this. But that's the sort of area that comes out here as being the one that one wants to think about. So then we gathered all sorts of information to try and see what is it about these areas. And so let me just sort of summarize that for you and then turn to some implications and questions. So the first sort of obvious thing is, well, how much of this is related to adverse behaviors that people undertake or health-harming behaviors relative to how those are treated? And not surprisingly, when you think about it, life expectancy is dominated by behavioral components. So there's a very strong correlation between the share of people that smoke and life expectancy at age 40. It's smoking among the low-income population, share of people who are obese, and the share of people who exercise, and life expectancy in the low-income population. Okay, so that's not so surprising. You see that in the upper part. We then tried, without much success, to correlate life expectancy for the low-income population with a number of other things. It is remarkably unrelated to various measures of healthcare access. So the percent uninsured in an area, or medical spending in an area, or preventive care receipt in an area. The one thing it is related to is fewer people dying after hospitalization, which is sort of not surprising that fewer people dying is associated with fewer people dying. So I don't give myself an enormous amount of credit for that, although if you want to give me more credit than I feel I deserve, I'd be happy to take the credit. It's a very tiny amount associated with income segregation, although in the opposite direction that people think about. That is, people speculate that more income segregation should be associated with lower mortality. It's actually with higher mortality. It's actually associated with lower mortality. It's not particularly related to various measures of social cohesion, not that these are perfect, but that these are measures that have been used in other studies. Nor is it particularly related to things like employment conditions. So it's not actually much related to unemployment rates or changes in populations or labor force, which I think of as a long-term measure of the growth of an area. And you say, well, how can that be? Because these are very depressed areas that people are leaving. And the answer is yes, but there are a bunch of red areas that people are moving to as well. So for example, Florida does relatively poorly overall, and that's an area where a lot of people are moving to. And there are other areas where people are not necessarily moving to, like rural New Hampshire and Vermont, that are actually doing very well. So it turns out not to be particularly related to these. What it is related to, and I'll just sort of show you these, not that I have a great theory for them, it's related to what you think of as a kind of strong upper middle class. The percent of immigrants in the population, median house values, high local government spending, the population density, and the percent of college grads in an area. Areas like that tend to have high life expectancy for low-income populations. And so the way to think about this, to put the puzzle a little bit more acutely, which is, why is it that low-income people in New York City don't smoke? If you can answer that, you've got a very good answer to this question. So that's the kind of thing that one needs to think about if one does this. It may be because high-income people don't smoke, and that's who they're around. It may be that local government does something to make it more difficult to smoke, although government policy is probably a lagging indicator, not a leading indicator. It may be that cigarette taxes are particularly high. Whatever it is, that's the nature of the thing which is particularly coming out here. But then, there's that, but then there's sort of a bunch of other things, like some of the cities in the South actually do quite well. Birmingham, Alabama has relatively high life expectancy for the low-income population. It's actually growing over time. And other areas that you'd think are growing, like Tampa and vast parts of Florida, are actually doing extremely poorly on the life expectancy dimension. So there are all sorts of puzzles here. That's partly why we put the data out, is so that people can go explore them. The Social Security Administration is helping with that task in a way that I can talk about if people are interested, but that is kind of very important. Let me switch from the data and then tell you what I think are some of the implications and policy questions I would like to know the answer to. One is just a sort of general statement. You often sort of hear about like population pulling apart, and sort of there's a rich and there's a poor. Actually, I don't think that's quite right here. Our data suggests that that's not quite right. I think a better descriptor here is that the population is just getting more heterogeneous. That at the high end, people are doing a lot better. At the low end, they're doing marginally better. At the very lowest end, probably not much better at all. The middle is sort of, there are fewer people in the middle, but not because the middle is being hollowed out into a rich and poor. It is still true that at any income, you're better off having a little bit more than a little bit less. And that it's just that is growing over time. So I don't think of this as a sort of 2 Americas or even 3 Americas. I think of this as maybe 100 different Americas corresponding to the different percentiles of the income distribution. And that's something that I at least try to keep in my mind as I think through this. The last thing, and then I'll stop, and then I would love to hear people's questions, comments, give time for general discussion. The first is the issue that I just raised earlier, which is what is it about sort of educated, affluent cities and the health behaviors? And the health behaviors are obviously dominant here in terms of the life expectancy profile, and I would sort of love to know the answer to that. Second, because these were income tax data, we didn't have any information on disability. And as I said, I can't really look at disability because I don't know, for people with no reports of income, how it is that what's happening to them. And so the mortality rates are just way, way off for them. So I'd love to be able to redo some of this with various other measures like disability insurance enrollment, or even direct reports of health status for people. And then there's sort of a bunch of policy issues. As I said, I have sort of vowed to myself not to particularly think about averages anymore, particularly about things like indexing and lifetime earnings and so on. But perhaps more generally is that this all suggests that survival is malleable and that we ought to be able to understand why, or we hope we can understand why, and do more things to enhance it. So that's where I wanted to stop. That was sort of a lot of information, but let me stop here and get comments, thoughts, and open it up to general discussion. Why don't we start off? David, go ahead, start off. David. I'm sorry, David Otter, go ahead, start off. Oh, sorry, we need a microphone. And then I'll come over here to you, ma'am.
So two questions. One, a clarifying question. So is it the correct, is the case that people in lower income percentiles in more affluent places just do better overall? That's the strongest correlate.
That is correct.
So that was just clarifying.
That is correct.
So here's a substantive question. You're looking at people age 40 and beyond, but there has been a lot of change in mortality among young, yes, and a big decline in sort of violent death among African Americans in the last 15 years. So I would think, would including that population change your view of how much of there has been growth in inequality of life expectancy by socioeconomic status?
So we can't do an enormous amount. We've done various things trying to look at other cuts. What if you don't do 40, but you do other ages, particularly ages below 40? When we did that, nothing much changed. Like little lines changed here and there, but not an enormous amount different. A lot of the increase in mortality that we've seen, like for example in the Case-Deaton work, is actually at ages above 40. You see it at younger ages, but where you really see it a lot is in people, say, in their mid-40s through their late 50s. So I suspect we're not missing a ton of that.
I was talking about the decline among young.
Oh, the decline in gun homicide. Yeah, the decline in deaths, that's actually particularly among kids, it turns out. So nothing to do with guns, but in general, child mortality has actually declined. And child mortality has actually declined more in areas where, with a higher poor population. So that might do some things here, although obviously we couldn't tell the income of the kids, but if you did it by some measure of parental socioeconomic circumstance, that might be important. Yes, ma'am, the woman in the blue jacket.
My name is Deborah F. Titus. I wonder if I can find a copy of a map like this right now in the book. Can I find a copy of this?
Well, let me ask a question. I'm happy to make the slides available. I also mentioned, is there a way to, there's probably not a way to pull up a website, but if at some later point anyone wants to pull up healthinequality.org, that has a link to the paper. It also has this particular picture and a number of other maps as well.
We can link that.
Okay, thank you very much. Thank you.
Hi, I'm Kim Muser from Boston University. I was very intrigued by your reporting of the finding that living in the effects of living in a segregated versus non-segregated area were kind of in the opposite expected direction. And I wanted to offer potential interpretation. I wonder if you looked into something like that. But there's evidence in terms of social comparison theory that one way to improve the quality of somebody's life is to expose them to less fortunate people. And so people, therefore, living in more segregated areas in lower income are less likely to be exposed to other people who are wealthier and potentially less stressed in terms of social comparison. In a slightly different, although maybe overlapping way, we know that being a minority, a racial ethnic minority, increases risk of developing schizophrenia. But interestingly, if the person lives in a neighborhood in which the predominant number of people are in that minority group, it offers a kind of protection. So interested in any thoughts about that, including effects of stress on mortality.
So those are both plausible. We took from these particular correlations here that we shouldn't make any strong statements either way. And some of this is a little bit surprising because there is, for example, literature on the relationship between income inequality and life expectancy. And our results are not showing the strength of things there. It turns out that if you look at it, we can actually match what the previous literature has because it's sort of observed for particular income groups like just above the poverty line and sort of things like that with a particular measure. But they, at least in our data, they're not as robust as we would like them to be. Like if you look at groups that you think would be affected even more, they're often not. In the sort of Gini coefficient, it matters a lot what you think about whether you actually have the income of the very highest earners. Think about New York. Its income inequality measure changes enormously when you include the people earning $10 million a year than if you don't include them and they're censored. So these things actually turn out to be much more sensitive than we would have guessed. And our general conclusion is that whatever is going on, the social environment here, this, as proxied by these, is not the dominant thing. And there may be something else, whereas these kinds of correlations are just much clear, like no matter what permutation you make of the data, you tend to see things like this. And so that's why I put a little bit more stock in these. But those are certainly plausible. John?
Yeah, so I always find these international comparisons fascinating, and there's been a whole bunch of research looking at health differences internationally. Has this research, provided some new insights on that? Because you talked about is it there are 2 Londons and 100 Americas, or is it differences in social programs, or any new insights from this research on what produces these international differences?
So I have been trying to find people in other countries. This is a great sort of advertisement for it. So I've been trying to find people in other countries who can get access to data and reproduce these pictures. And I would love to be able to do that, both in a sort of, this is a kind of relative sense, that is, people are ranked by income percentile. But one could think about also doing, say, an absolute income relative to the median, so you could see, go the same distance from the median as people are in different groups. To my knowledge, no one has been able to do this detailed a picture in other countries, although the data for that exist. There are a few people who I know who have seen this and contacted us about, gee, look, do you think it would be of interest to do this in other countries? And I always respond back, yes, absolutely, it would be. But I would love to be able to do an international comparison of this. My suspicion is that what we would find is that, at least at the bottom, that it doesn't drop off as much in other countries. That there's probably something about the social safety net in other countries that keeps at least more of a floor. Now, whether that's because of the safety net, which I sort of said, or whether that could be because of other social circumstances, I don't particularly know. But I haven't seen anything that would allow one to make this comparison.
I have one more question then. Let's say that for a moment you were running a research office for the Social Security Administration, just say, and you had one key research question that the agency should look at with regard to this. What would it be? I'm looking for ideas.
So I want to come back here, and maybe other people might have thoughts on this as well. But I want to come back to, I would say a couple of things. One is I would take these and I would try and say, how does it affect the, so take these and do various calculations about what's happening to the progressivity of the Social Security retirement system and survivor system over time. Because these are very, very big changes, and so they're going to have big changes in the progressivity there. And then the other thing I think that's really important is a lot of our forecasting about Social Security is going to depend on what we think is going to happen to these kinds of trends. And so I would really try and understand more about that. And this is something that actually Social Security is working with us to help research groups use the data that we've put out, which I think is incredibly wonderful and important for Social Security to be able to have that information and then to say things like, what could we do about this? Or even if we can't do anything, how do we monitor to sort of know what's likely to be happening?
Any other questions? Please join me in thanking David. Please enjoy the rest of your lunch. We'll start up the program shortly.